Hello, today we have a very exciting presentation, which is the evolution of reciprocating instrumentation. And I have entitled this presentation, The Golden Era of Reciprocating Instrumentation, because truly we are in a golden era of those instruments right now. What are my presentation objectives today? First of all, I would like to introduce revised basis for cleaning and shaping objectives. Second, modifications to current philosophies in cleaning and shaping. And this will be, I hope, the hardest part probably to convey to you, because you have already philosophies that you have acquired when you were a student or a postgraduate student, and philosophies that have changed during your professional lives. Understand instrument design, movements, and effects on instrument failure. Instrument failure means instrument separation, no case failure. Also, I will talk about instrumentation protocols and appropriate file use, the DFUs of these instruments, and recognize safety and efficiency concepts for mechanized nickel titanium instrumentation. When I say safety, we need to understand minimal preparation. We need to start thinking, how much tooth preservation am I leaving after root canal preparation? Also, I will try to emphasize to provide biologically and scientifically acceptable clinical therapy, biologic foundations of current objectives and relevance to clinical research, the importance of best evidence-based endodontics, and we will pull away from establishment of treatment principles from empirical or anecdotal evidence. The future of endodontics. And truly, the future of endodontics, it's bright. It is interesting that many companies in the world, especially the ones that manufacture endodontic products, will put a little emphasis on research. In research, even before the instrument comes into market. But if a new file is going to be introduced in the market, the best thing that we can do is to really understand that instrument. If we remember when we were in dental school, we used to do root canal therapy with an instrument. And we never had, in those days, stainless steel, and we really never had a class of metallurgy. Neither we had a class of geometries. Neither we have a class of chemistry in endodontics when we talk the subjects, because all this plays a big understanding of these instruments, what we're doing. So we need to understand this instrument. Second, can the instrument reduce all of intracanal bacteria? We know that that's impossible. The instrument has to be combined with irrigation. And please remember, my dear colleagues, irrigation is the most important part of root canal therapy. Can improve incorporation of canal space and cleanliness. Can really someone invent an instrument that engages in all the canal walls, cleans, and really take care of that dentin? We know because of the complexity of root canal anatomy that it's impossible. Moreover, it will never be able to achieve that one instrument will engage in all the canal walls. Can maintain canal wall integrity. Unfortunately, until today, we have the buccal lingual view of the X-ray once we remove the clamp and rubber dam after we have performed that root canal to ascertain how much canal integrity we have left. And just please remember that an X-ray, it's a bidimensional representation of a three-dimensional object. It really depends what type of instruments, the movements of the instruments, the design of the instruments that we will need to preserve dentinal structure. And improve instrument failure resistance. Can a company really invent an instrument that is difficult or is impossible to separate? We know that any metal has inherent in their structure that problem. But nowadays, with all these new technologies in metallurgy, the advancements in metallurgy, today to separate an instrument is almost an impossible task. Let's talk about the history. What is the past? The past of nickel titanium comes about in 1991. That's the first generation. We have passive radial lands, we have fixed tapers, and we have one cross-section. We have instruments that only whatever we section was one design. And then we have from companies that launched into the market in that era a package of 4 instruments to prepare a root canal, and some of them 18 instruments to prepare a root canal. Then the second generation is in 2001. Now we have active cutting edges. Now we have a file that really engages in the canal wall and cuts instead of the previous generation that scrapes the canal wall. We have changing tapers. Now we have different tapers. It's not a constant taper. We have different tapers in the active portion of that file. And we still have the one cross section. It means that wherever we cut that file, we will have the same design. And again, companies from 4 instruments to 18 instruments. That's the past. If I can call the present, when did the present start? The present starts in 2007. Why? It's the new Untitled metallurgic changings, the evolution of metallurgy. And at that time in 2007, 2 companies were in the market with different type of nickel titanium. Then in 2010, we have the other generation of files. Now we have a file that it's very active. It has changing tapers. It has 2 cross sections on the file, and it's only 1 instrument in 95% of the times to perform root canal therapy, and it has unique movements. Then look at the dates, 2012, 13, 14, and now 15. We have a file that has an active, it's a very active edges. It has changing tapers. And again, the metallurgy, the improvement of the metallurgy have changed. Now we have different colors. We have blue, we have gold. That's why this presentation is the golden era of root canal instrumentation, or root canal reciprocating instrumentation. If we look at the history, and we have everything right now in front of us, from the first generation to the second, 10 years, from the second to the third, 7 years, from the third to the fourth, 3 years. And then every single year is changing. Why? Because technology. And now the endodontic field has really embraced all these changes in technology to provide better treatment for our patients. Reciprocation is nothing new. In 1958, Roger Blanc in France invented this contriangle, which it was called the gyromatic. And since then, we have gone on and on with different devices through the years that they will do reciprocation movements. It is important to understand that the desired canal shape can be prepared with virtually any series of instruments. But what is important is that the risk and efficiency that varies from instrument to instrument, and sometimes from company to company, the risk and efficiency of these instruments. It was in 2010 at the IFI meeting, at the World Endodontic meeting in Athens, Greece, that it was launched Wave 1. Since then, we have been working very, very hard to improve this instrument. We've been working since 2011, Dr. Cliff Roddle, Dr. Willie Pertot, Dr. Julian Weber, and myself, to bring you Wave 1 Gold. That has remarkable improvements over Wave 1. This is the logo, and these are the files Wave 1 Gold. It comes in a pre-package, like any other instrument, pre-sterilized, which is very important. Most of the instruments nowadays in the market, you have to sterilize. But Wave 1 Gold, like Wave 1, comes pre-sterilized. There is no need to sterilize this instrument. Single instrument, you can, in 95% of the time, use only 1 instrument to do the entire root canal treatment for the patient, the cleaning and shaping. Single use, you can only use this instrument 1 time, and it's a very simplified root canal therapy. The embracement of these instruments has really gone wild worldwide, because many general dentists as well as endodontists have seen how simplified root canal therapy has become. Let's talk about improvements. Let's talk about what was before and what do we have today. 3 columns, very distinctive columns, the design features of Wave 1 and Wave 1 Gold. And as you can see here, it's exactly the same in these features from Wave 1 to Wave 1 Gold. Now, what we have different is the instrument sizes. In Wave 1, we had 3 different sizes. In Wave 1 Gold, now we have 4 sizes. The instrument tapers have changed in Wave 1 Gold. We made it more efficient by these tapers because also we wanted to preserve more dentinal structure. Instrument tips, it's different. Before we had a modified guiding tip, now we have a semi-active tip. It's a tip that it will go and start cutting a little bit when it starts looking for the canal. Then cutting surfaces. Before we have only 3 blades, now we have 4 blades. And in these 4 blades we have 2 points at all times, every 200 microns that is engaging on the canal wall, and it has a reason why, because this instrument will remain centered in the long axis of the canal. The helical angle and pitch is different. Why? The helical angle now is a constant angle, but the pitch is still variable as before. The rank angle is the same in both files. The transverse cross-section in way 1, we have 2 different designs. Now we have improvement on the file in the parallelogram. Why? Because it will auger the dentinal debris more easier to the coronal area. With the metallurgy, before was the M-wire, which is a pre-cut process, and with way 1 gold, it's a post-cut process. And the heating of this instrument is the one who gives the color as gold, and this will give this instrument incredible properties that it has never had before in cyclic fatigue, torsional strength, flexibility, and bending, as we are going to discuss later on. Also, it comes in a pre-sterilized package, and the same as previous before, the same length, 21, 25, and 31 millimeters in length. Now, these are the instruments with the tip sizes and tapers, these 4 new instruments of way 1 gold. Here's the small one, which has a tip size of 20 with a taper in the very first 3 millimeters of 0.7, and then you have a comparison chart of an 0.4 taper and an 0.6 taper, so you can understand how much tooth structure we are removing with this type of instrument. Here we have the primary file. In its first 3 millimeters, it's an 0.7 taper, and then we have the maximum file diameter at D16. We have a comparison chart of an 0.4 and 0.6 taper, so we can understand how much tooth structure we are removing. This is the middle file, the medium file, which is a 35 at the tip with the very first 3 millimeters of 0.6 taper, and the maximum file diameter in D16, again with the comparison charts. And now we have here the large way 1 gold, which is a 45 in D0 with 3 millimeters of an 0.5 taper and the maximum file diameter at D16, and again with the comparison charts for you to see. This is a schematic representation of a regular nickel titanium. This is the M wire, which was placed on way 1. It was a regular nickel titanium, and before it's cut, they change this metal to have larger spaces between the crystals of that nickel titanium. And now we prove that when we wrote this article, and the benefit at that time to use an instrument that has the M wire because it was lasting longer in cyclic fatigue. Now the improvement with way 1, here we have cross sections of the instrument looked at the scanning electron microscope of the M wire and the regular nickel titanium. We can see the differences, same as here of a regular nickel titanium and the M wire. So with way 1 gold, this is one of the most important changes that has been applied to this instrument. When the nickel titanium, regular nickel titanium, it's made, they will cut these rods, then the instrument is grinded, and after the instrument is grinded, it goes to a heat process. This heat process will give the instrument the gold color. Then the rubber stop is placed, then the handle, and this is one of the biggest improvement in way 1 gold because it will give us tremendous properties in cyclic fatigue, torsional strength, flexibility, and bending, as we are going to discuss later on. In the past, we have 2 designs of way 1. From D1 to D8 was a modified convex triangle, and from D9 to D16 was a convex triangle. In way 1 gold, we have changed that. In way 1 gold, it's a parallelogram right now. And why we change this? Because by changing this cross section, it will auger the dentinal debris much easier to the coronal area. Now we have the tip. also a big improvement. In the past, we have a non-cutting tip, a guiding tip, and now we have a semi-active tip, as you can see with these scanning electron microscopy photos. What this will bring us is that the file will advance inside the canal with much less effort or without applying the amount of pressure before, apical pressure before. Motors. The beauty of that, we do not need to change motors. We can continue using the same motors as Wave 1. But it's very important to understand that has to be the motors designed by the manufacturer of Wave 1 and Wave 1 Gold. Why? Here we have the science that clearly has stated that to have the benefits of the file, you must use the manufacturer motors for this Wave 1 Gold instrument. Let's talk about research. There are incredible articles in the Journal of Endodontics, International Endodontic Journals, OOO, and many other peer-reviewed journals about comparing or analyzing endodontic instruments. This particular article came in 2009, and they used this specific jig to compare these instruments. And since 2009, many articles has based their research study on this jig. And this is the jig that we are going to talk about because this is the jig that we use to test Wave 1 Gold. First, this incredible endodontist is a combined effort from 3 universities, the main in Spain, in Florida, and in New York. And what they have done is to test the cyclic fatigue of a single file system, Wave 1 Gold. This is the methodology. They use 20 instruments at a time. They use the E-motor from Dentsply. Then they use this standardized jig that has 45, 60, and 90-degree curvature. The test was done on the 45-degree angulation of Wave 1 Gold, penetrating at 23.5 millimeters because of the rubber stop, which is a little larger than half a millimeter. And then the statistical analysis was done applying the CRISPR test. These are the photos of the instrument machine and the stainless steel jig, as you can see here. And I'm showing you right now the last seconds of the cyclic fatigue test. And why the last seconds of the cyclic fatigue test? Because that's how long it took this instrument to fail on the cyclic fatigue. These are the numbers of the cyclic fatigue test. This is the maximum load in newtons that they apply until the instrument failed. And when they compare Wave 1 Gold to Wave 1, a two-way ANCOVA was conducted to determine a statistical significant difference between Wave 1 and Wave 1 Gold on the degrees of rotation until fracture. There is a significant effect of file type on degrees of rotation until fracture after controlling for a file's flexibility and mass. Wave 1 Gold demonstrated superiority cyclic fatigue in a 17.5% over Wave 1. Also, they did the study on flexibility of Wave 1 Gold. They applied the same methodology because we need that jig to test the strength that you need to take the file all the way down. And also they apply a descriptive test for the statistical analysis. Here are the results, the rotation in degrees and also the amount of force in torques per gram per centimeter. And it was important to also analyze the 3 millimeters. Why? Because all these incredible researchers have noticed when they compare Wave 1 Gold with many rotary systems or reciprocating systems, that the discrepancy, the tremendous discrepancy that there was in some of them. So they measure all the D3s from D1, D2, and D3 on all the other files, and it's obvious, as you can see in this box, the tremendous difference between the 3 files. The researchers has expressed to me that in this case, the 3 files were completely different in D3. So the results of Wave 1 Gold compared with Wave 1, a two-way ANCOVA was conducted to determine a statistical significant difference between Wave 1 and Wave 1 Gold on force of torsion. There is a significant effect of file type by force of torsion after controlling for a file rotation and torque. Wave 1 Gold demonstrated a superiority resistance to fracture in 53% more than Wave 1. Now, another test, which is the bending test. They took 10 files from Way1 Gold Primary, a machine that has been built by my leffer in the manufacturing plant that, following ISO norm 3630, the file was clamped again in the first 3 millimeters and bent up to 90 degrees. Then they calculate the force of flexion and the residual angle that it returns to. And for Way1 Gold, they apply a descriptive test. Here we can see how this test is done. The file is clamped in the very first 3 millimeters, then it's pushed to 90 degrees, and then they let the file come back to a residual bending position. Here are the results of the force of flexion and also the residual angle that ends up with Way1 Gold. So the results of the bending test, a two-way ANCOVA was conducted to determine a statistically significant difference between Way1 and Way1 Gold on force of flexion. There is a significant effect of file type by force of flexion after controlling for a file flexibility and mass. Way1 Gold demonstrated a superior force of flexion of 87.5%. and a tremendous 147% in the residual angle. Okay, now let's get into how are we going to use this file. It is very important always to follow directions of use, DFUs, that the manufacturer has set forth to have a good experience with this instrument. If we're trying to vary the technique, we are going to run into procedural errors. It doesn't matter what you use. In this case, it's an endodontic instrument, an impression material, you name it. It is very important always, please, to follow the manufacturer's directions for use. With Way1 Gold, we do exactly what we did with Way1. First, we ascertain that the tooth requires endodontic treatment. After that, we ascertain that the tooth is restorable. After that, anesthesia, clamp, rubber dam, and then we'll do the access. We need to remove all the decay. It's cardinal rule for endodontic therapy. We never go inside the root canals without eliminating all the decay. After we eliminate the decay, we eliminate all the enamel without support. And now when we eliminate all the enamel without support, then we see that it's a must to have a pulp chamber that can host, that can be flooded with the chemicals. We need to understand that irrigation is the most important part of root canal therapy, and we need to apply time and also new technology in irrigation. So we need to build up that pulp chamber. Once the pulp chamber is built up, then we will ascertain if the canals are patent. We will take a very small instrument, hand instrument, stainless steel, a number 8 and number 10, where we are going to explore those canals with our 2 fingers. These are going to be like our eyes, feel where those curvatures are. Once we ascertain that the canals are patent, now we need to establish our working length. In the vertical dimension, is the most important to use an apex locator. Nobody can really do very good root canal therapy without the aid of an electronic apex locator. An X-ray is not enough. An X-ray is a bidimensional representation of a 3-dimensional object. Once we ascertain that length, that vertical dimension of the canal with an apex locator, we will take an X-ray to corroborate that measurement with the apex locator. After that, we will now require that before we start working with any endodontic file, Way1 or Way1 Gold, we must create a glide path. What is the glide path? We are going to show is the road map for files to follow. We are going to show all the files what is that road map that they need to follow. For that purpose, we will take this instrument which is called the ProGlider. The ProGlider will be very, very helpful in helping us at that working length to create the glide path for Way1 to follow. After we have completed our glide path with ProGlider, we will take Way1 Gold and we will go in increments of 3 millimeters inside the canal. That's the amplitude stroke every 3 millimeters. We will remove the file, observe the file if it has dentinal debris, clean those dentinal debris, irrigate, and every time that we irrigate, the needle will be penetrating deeper and deeper into the canal. So we irrigate. After irrigation, we take that file that we established the working length with, and then we will ascertain that we have not blocked ourselves. In other ways, we are going to recapitulate. After that, we irrigate again, and then we go back with way 1 goal for another 3 millimeters in an amplitude stroke, down apically. And we repeat exactly the same steps. We remove way 1, we observe the instrument, we clean the dentinal debris that it's in the flutes of the instrument, we irrigate. Now you will see that the needle will go deeper and deeper. Then we take that instrument that we established, that working length, we ascertain that we have not blocked ourselves. It goes all the way to working length. Then we irrigate again, and then we repeat the same process with way 1 goal until we reach working length. Please, don't take the instrument in one instance, in one stroke, as far as you can, because the instrument was not created to do that. The beauty of the new cross-section of way 1 goal will allow all the dentinal debris to come up coronally. So we need frequent irrigations, and you will be able to see with loop or with the operating microscope all those debris just coming up. And we are not going to block ourselves by virtue of recapitulating every single time after way 1 goal comes out of the canal, and then we're going to be able to achieve a very good working length with way 1 goal. Let me take you right now through a plastic block. Here we have irrigations, as I mentioned before. It's a critical part of root canal therapy. We irrigate. Now we are going to establish that patency in the canals. We are going to go with a very fine instrument, a number 8 and number 10, and to see that we are able to go a little bit beyond the apex. Not that much, just half a millimeter. We irrigate again. Every time that a file is used inside of canal, it requires irrigation. You can see here how far the irrigation needle goes. Now we establish that working length. Here you can see that the instrument is very, very tight. We're almost at working length. We attach a clip for the apex locator. You are going to start hearing now when it gets to the apex right there, beep, 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 beep. That means that we have achieved that vertical dimension with the electronic apex locator. We will adjust the rubber stop, we take the file, and now we have acquired that vertical dimension, the working length. We measure that, we record that, we will irrigate. Remember that every file that comes out of the canal requires irrigation. And now we are going to proceed to create that glide path. In this case, we use the Pro Glider. In increments of 3 millimeters, we go all the way to working length. We irrigate again. We ascertain that we have not blocked ourselves with the instrument that we established that working length. Then we remove the instrument. We will irrigate again. And now we are going to proceed the canal shaping with way 1 gold. In amplitude strokes of 3 millimeters, we will initiate that instrumentation. You can see here clearly how effective and efficient is this instrument. Now the irrigation needle is going to penetrate deeper and deeper into the canal, just the space that has been created by way 1 gold. We'll remove the irrigation needle. Now we will check, we will recapitulate, we will be sure that we have not blocked ourselves. And for this purpose, we use the file that we established working length with, irrigate again, and then we go to the second time with way 1 gold, another 3 to 4 millimeters amplitude strokes. You can see the efficiency of this instrument, how it cuts dentinal walls. We observe the instrument that has the debris. We clean the instrument. We go back now even deeper with our irrigation needle. Irrigate, irrigate. We ascertain that the canal is still patent with the file that established working length. You can see the deeper penetration of our chemicals during root canal therapy with the side-vented irrigation needle. And now we will go in this instance all the way to working length with wave 1 gold. As soon as we achieve that length, when the rubber stop touches the reference point, we don't need to continue reciprocating inside the canal. You can see the efficiency of this file in conventional chips. We clean the instrument. We will irrigate with the needle now as deep as we can. Always the needle has to be loose in the canal. It can never ever be lodged inside the canal. We irrigate. Once again, we will ascertain that we have not blocked ourselves with the very small instrument that we established working length. After that, we will irrigate again, and now we go through the irrigation procedures. In this case, we're going to be using the endoactivator with sodium hypochlorite, and then we will rinse the canal. Then we will use other solutions as Q-mix, or on another case, EDTA. Now we are verifying with a size verifier that we have sufficient space in the canal to receive our core material for obturation. We dry the canals very well. After drying the canals very well, we need to place some cement. And we place the cement at the entrance of the canal. Then we remove the excess of cement. It has to be a very, very fine layer of cement. We use cements, and then we insert the core obturator until it reaches working length. You have seen how easy it is to fill the canals also in this case with Goracore. Wave 1 gold will have also paper points and good aperture points, obturators, size verifiers that matches the taper of wave 1 gold. After you have seen the use of wave 1 gold on a plastic cube, let me take you through a clinical case. And now we are going to see this lower molar done with wave 1 gold. Here we have the tooth that has been ascertained that requires root canal therapy and is restorable. We do the access opening. After our access opening, we remove the contents, in this case with an instrument of the pulp chamber. We ascertain that the canals are patent with a very small file. You can see the fluids on the very flooded pulp chamber. Once we ascertain that patency, we will need to create that glide path with the ProGlider rotary instrument. We are irrigating here, and once again, that pulp chamber has to be flooded, always flooded with the chemicals that we use. In this case is sodium hypochlorite. And after we have established the working length, we create the glide path. As you can see here with the ProGlider rotary instrument, we are going little by little in amplitude strokes of 3 millimeters all the way to working length. Sometimes it takes several steps to achieve this length. And after that, we irrigate the canals. We verified that the canals are still patent. We make sure that we have not blocked ourselves. And then we use wave 1 gold in amplitude strokes of 3 millimeters inside the canal. We can see on the left that we are irrigating. We see very clearly in the center that we're making sure that the canal is still patent. And after a file comes out of the canal, more irrigation is required. Then we continue with wave 1 gold for the second time. Now I'm pretty sure we are preparing the middle of the canal. Amplitude strokes of 3 millimeters, 3 to 4 millimeters. We irrigate. We make sure that we have not blocked ourselves. And then we irrigate again. And then we continue until we reach working length with wave 1 gold. And this is what you are looking right now. I think that this was the last step on the use of wave 1 gold. And now the canal has been already prepared. Then we will irrigate, make sure that we have not blocked ourselves, and irrigate again. After that, we irrigate. We make sure that the canal has not been blocked. We irrigate again, and now we proceed to use the technology like a endoactivator to remove the smear layer before we are going to obturate the canal, and we can use solutions as Q-Mix in conjunction with the endoactivator. New methodologies are available today to study the performance of these instruments, and one of those is a micro-CT. Let me take you through a micro-CT analysis of the performance of Wave 1 Gold. Micro-CT is a beautiful methodology to study root canal instrumentation and root canal obturation. What you see here is an extracted molar, and I want you to please pay attention on the complexity of the anatomy of this tooth. This solid tooth now is going to turn, and you're going to be able to see that anatomy that I spoke about, the complexity. Look in the red, and look at the curvature of those mesial canals. Not only the degree of the curvature, but also at the apical area, the radius of that curvature in that mesiolingual canal. Then, what you're going to see next is how the canals has been instrumented with Wave 1 Gold, with the long curvature in the mesial buccal and in the mesial lingual, with that sharp radius of the curvature, and then the canals has been filled with a core obturator, which is Godacor. In conclusion, my colleagues, I have taken you through the history of reciprocation movements in endodontics. I have taken you through the improvements of Wave 1 Gold versus Wave 1, which are the sizes of these instruments and tapers, the metallurgy, the cross-section, the tip of the instrument, and we have gone through research. And I'm pretty sure very soon you are going to be seeing more and more research in very good peer-reviewed journals. And in that research, we need to, please, not to forget the incredible cyclic fatigue resistance that this Wave 1 Gold instrument has, the flexibility that has compared with Wave 1, the torsional strength, and the bending. And I have taken you through the directions of use. We went through a plastic block, we went through a clinical case, and we show you a extracted teeth, ascertain the performance of this instrument through an incredible technology, which is a micro-CT. You have seen how well this instrument will prepare the canals without procedural errors. I'm convinced that you are going to incorporate this instrument in your armamentarium. I'm pretty sure that you are going to use this instrument very, very soon.